United Kingdom, and most of our rectopexies are now sutured or mesh rectopexies, and a small proportion are resection. So why is there so much talk of perineal operations? It is believed that perineal operations have a lower morbidity, which is counterbalanced by a higher recurrence rate. As they say, every problem has a solution and every solution has a problem. So we need to look at to separate the wheat from the chaff. Looking at the Altomeyer's operation and the Delorme's operation, the recurrence rates really range between 0 to 20% in a wide range of series, which I've looked at from 1994 to 2006. Two modifications of this are: one is the STAR operation, first described by Antonio Longo, and it is our policy to offer this when a patient is unwilling for abdominal procedure. Particularly, you have a young male, when we counsel them about problems of nervi erigentis, often refuse abdominal procedure, and we then offer them, if the prolapse is less than 4 centimeters, we offer them the STAR operation, which is a stapled transanal rectal resection. I won't play too many of the details because there's a lot more to cover. We published our data on STAR in the World Journal of Colorectal Surgery in 2016, and we find that the success of STAR for obstructive defecation is about 92% at 1 year, but wanes to come down to 64% at 5 years. So that's an eye opener. So it's chicken and the leg. What comes first? We then described a modification of the Altomeyer's using linear staplers, and we published this in the Journal of the Association of Surgeons of India, the Indian Journal of Surgery in 2015. We call this the perineal stapled prolapse resection. It's a very simple operation using 2 or 3 linear cutters where we divide the full thickness of the rectum and oversew the entire staple line. Again, a good operation that could be done under regional anesthesia, particularly for elderly unfit patients, but the problem remains of recurrence, and our own data is about 14% recurrence at the end of 5 years. This can either be done with a linear stapler or with a contour, as you see me doing here, and this was a published data. We've now done about 26 of these PSPRs. But really, look, is really the perineal operation meant for high risk? And I personally don't believe so. This is a paper in Surgical Endoscopy in 2015 showing no significant difference in risk-adjusted morbidity and mortality between laparoscopic and perineal surgery for prolapse. So the conventional thinking that elderly patients, regional anesthesia, and perineal procedures, I think, needs to be rethought. And this is a paper published by Fang in DCR of 2012 considering this. Let's briefly look at the abdominal procedures. The original thought was the Evalon sponge by Wells in 1959, but there were obviously problems with the sponge and has been given up and replaced really with polypropylene meshes posteriorly, which have a very acceptable recurrence of between 0 and 5%. It has low recurrence, low mortality, though obviously putting a mesh behind the rectum is a problem. And not only if the patient has constipation pre-op, it gets worsened, but about 20% of patients after a posterior dissection can get de novo constipation, which is a disaster. There is a dichotomy I see between American literature and European literature. Most of my training was in Europe, first in the United Kingdom, then in Germany. I had some time to visit Dr. Duhur, and I was always more in favor of the rectopexies, but the Americans do the Friedman-Goldberg operation, much more common, where we resect the redundant sigmoid and also do a sutured rectopexy posteriorly. Excellent recurrence rate, takes care of slow transit constipation, but obviously, like any anastomosis, there is a morbidity. I think the world over, I think it's very clear that the mesh posteriorly has been replaced by posterior sutured rectopexies, which have equally good results with perhaps lower morbidity in this procedure. So overall, if you look at this, the abdominal operations have between 0 and 6% recurrence, while the perineal operations are between 0 and 20%. But most importantly, functional outcomes are unsatisfactory in almost 50% of patients after posterior rectopexy. Now, why does this happen? It's usually because of mobilization of the rectum with the accompanying autonomic nerve injury and the dysmotility that happens in the rectal ampulla. I had an opportunity to work with Dr. Duhur for a short period of time, and he was the man who first described the ventral mesh rectopexy for rectal prolapse and subsequently also for obstructive defecation. The important part is this not only improves the incontinence, but improves constipation in about 20% of patients. The key issue is, how do we look at patients with tricompartmental prolapses? How do you handle young women who are sexually active? And are we concerned about meshes? I think the word mesh, particularly in the south of England near Bristol and Oxford, is a bad word. But I think I'm going to talk a little bit about this as we go on. We have strong data from our own center as well as from another center in North India looking at the effect of laparoscopic ventral mesh rectopexy for full thickness rectal prolapse, showing excellent results, both only structural as well as functional results. So these are two operations that we have done. The one on the left is a patient who has a walled prolapse, a cystocele, as well as a full thickness rectal prolapse. I do this operation nowadays robotically or always almost completely with a mono and bipolar. We don't really need to use much energy sources. You see me actually pushing the vault up. What I tend to do is put a Y-shaped polypropylene, mid to low weight polypropylene macroporous mesh. I usually do a Y-shaped mesh in case there's a vault prolapse. One limb of the Y goes on the vault, one limb goes on the rectum, and the proximal part of the proline mesh is sutured onto the sacral promontory. The key issue in this operation is to go right up to the pelvic floor. And I find using a monopolar hook beautiful for this. You get these planes like you see me on the right-hand side. You go right down to the endopelvic fascia on both sides. Important to divide the rectovaginal septum completely till you come to the lower part of the vagina. Often we get someone to put a finger in the vagina to lift it for us, and our choice is to use a lightweight macroporous polypropylene mesh. A biological mesh in India costs 60,000 rupees, which makes it approximately 700 sterling pounds, which puts it out of the reach of most patients. So I do offer this only in patients who are young and who are sexually active. The shape of my mesh really depends on the imaging and the problem the patient has. But generally, if it's only a rectal prolapse, it's an L-shaped mesh. I deliberately suture the mesh to both the levators with the idea to lift the pelvic floor and also slightly improve the middle and anterior compartment problems. If the patient has a vault prolapse, like you see me doing here, I will use a Y-shaped mesh like you see me. We published our data in the Journal of Minimal Access Surgery in 2020, and we have now done more than 170 ventral rectopexies for obstructive defecation and full thickness prolapse. And at 5 years, our data is about 88% satisfaction. Some questions still remain to be answered. Soft polypropylene versus biological meshes. We have now switched over to using PDS as opposed to Ethibond. Our failure rates so far have been fairly acceptable at 5 years. The concern really is dyspareunia and mesh infection. This is a patient who had a vaginal mesh placed elsewhere in the country. We found a piece of polypropylene coming through the vagina, and the patient had recurrent abscesses. So I want to make a very clear dogmatic statement, if you like. Never put a mesh through the vagina. Be very careful of mesh in younger patients. Make sure you counsel the patient well and only then use a mesh adequately. I want to just point out for the youngsters the PROSPER trial, a randomized trial published in colorectal disease in 2013, looking at abdominal versus perineal procedures. I have two other flow charts, a little busy, I'm afraid, but I like this chart because I make my decision based on the anal sphincter function. On manometry, if there is a pelvic floor dyssynergia, I will not operate on the patient till he or she has had pelvic floor retraining to improve sphincter function. If the patient has an anatomical abnormality, be it a rectorectal interception or a rectocele or an enterocele, generally my choice is a laparoscopic ventral mesh rectopexy, usually with using macroporous proline meshes. We have earlier been more keen on the internal Delormes or the star or the TransStar, but my enthusiasm for this operation has been waning as I look at my own data over 5 years. Another busy slide. If the patient is medically fit, we do a defibrography. And if it's multi-compartmental with MDT, we do a sacrocolpopexy or a ventral mesh rectopexy. Isolated rectal prolapse gets a posterior mesh rectopexy or a sutured mesh rectopexy, and only very high-risk patients get perineal operations. 4 messages. The first thing I tell my fellows is learn all the operations. The problem is we are all dogmatic and fixed on one particular operation and like to do the same operation based on our dogmas for all patients. It is important we tailor the procedure to the patient's fitness and anesthetic risk. Talk to them about judiciously do VMR in women with middle or tricompartmental problems. Please counsel them on the problems of meshes. There are potential mesh complications in India. Surprisingly, a large proportion of our patients of obstructive defecation and two compartment problems, almost 30% are men, predominantly women, and much more elderly patients. We currently reserve the perineal operations for very elderly unfit patients, explaining to them the higher recurrence rates. But clearly, posterior suture rectopexy is as good as posterior mesh. Ventral mesh rectopexy does add a mesh, but is superior and avoids de novo constipation. To finish off, ladies and gentlemen, overcome the instinctive mistrust of the new, yet avoid over-enthusiastic, uncritical adoption of unproven methods. Thank you very much.
Thank you, Roy. That was a very good disposition and rich with personal experience. And your publications also prove that the fact that you have been an expert in this field, and your contribution for today's topic has been immensely of help. I would request now Dr. John Robertson to introduce the next speaker, Mr. John Camilleri Brennan.
Thank you. And thank you, Dr. Patanker, for a great talk there. As you've said, I'm John Robertson. I'm a colorectal surgeon in Scotland and a member of the Royal College of Physicians and Surgeons of Glasgow Council. I'm delighted to introduce our second speaker on the assessment and management of pelvic organ prolapse webinar. John Camilleri Brennan is a consultant general and colorectal surgeon at Forth Valley Royal Hospital and an honorary clinical associate professor at the University of Glasgow. He is surgical vice president of the Royal College of Physicians and Surgeons of Glasgow and responsible for surgical education. John is a graduate from the University of Malta. He trained predominantly in Dundee and Aberdeen in Scotland, with a travelling fellowship period with the Colon and Rectal Surgery Associates in Minneapolis, USA. His research has been on rectal cancer that led to a doctorate from the University of Dundee. John's specialist interests are in colorectal cancer and pelvic floor surgery, and he has a keen interest in surgical education and research. Prior to being elected as surgical vice president, he had served as associate director of surgical examinations, college tutor, regional advisor, and member of council. He's the principal investigator in a number of research projects and has published articles in major surgical journals and co-authored chapters in postgraduate surgical textbooks. So, ladies and gentlemen, I'm delighted to introduce and give you John Camilleri Brennan. Thank you.
Thank you. I would request the speaker, Dr. John Brennan, to take over.
Thank you very much for that very kind introduction, Mr. Robertson. Ladies and gentlemen,
Roy,
yes, I will share my screen. I've got disabled share here.
Okay. Just a minute. Roy, you have to transfer the host to Roy.
I've already stopped sharing, Siddesh.
But I have made you the host, no? So
how do I change? I think, can you do it from your end?
Yeah, no, you have to. Okay. Now I will make Brennan. No. Host disabled participants in sharing. Who is the host? He has to ask. Avneet. Avneet, you have taken over as the host. Please enable Brennan.
Dr. Roy is still host. You need to leave it, sir.
No, he has done it. He has disabled it. Roy has disabled. Roy,
Tell me what I have to do. I have already stopped sharing.
Yes, yes.
You tell Roy
Now
what.
it's Association of Surgeons. Yeah,
Can you
now
check it,
it's
sir?
yes,
Can you check it, sir?
it's done. It's done.
Now it is done.
Yes.
John, you can go on.
Can you see my screen?
Yes,
Yes, we can see it.
we can see and hear you very clear.
Thank you. So, can you see the PowerPoint presentation clearly?
Yes, we can.
Okay.
Maybe you can go on to the slideshow mode.
Is it better now?
No, we can't see your screen.
You cannot see
You
my
are
screen,
sharing.
all
You are
right.
screen sharing, but you are not on the right. You open your PowerPoint and yeah, you click on the PowerPoint. Yeah, now it's there.
It's there. Okay.
Yeah, yeah, you can make it on slideshow now. Yeah, you're fine actually. You can see no.
Yeah, you can
can-
go on. You can go on.
You can go on with this only. Yeah, you need not go on to the
Okay.
slides. You can see
I'll
your-
continue with.
Yeah, we can see the screen. We can see the screen.
You can see the screen. That's
Yeah, we
good.
can.
Okay. 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 Can you see the screen? Well,
Yes,
the
we can.
PowerPoint.
We can.
Good. Okay.
We can
Thank
see
you.
the screen.
So it's my honor and privilege to be selected to present in today's webinar, which is jointly hosting our college with the Association of Surgeons of India. And I'm going to speak about pelvic prolapse, but focusing mainly on posterior compartment prolapse. So my presentation is going to overlap slightly the previous presentation. So pelvic organ prolapse, this occurs due to weakening of the various ligaments and pelvic floor support. And the pelvic organs are displaced from their normal anatomic positions. Patients are usually asymptomatic, so pelvic organ prolapse may be picked up as an incidental finding. However, some patients present with obstructive defecation, a sensation of a bulge in the vagina, and erectile swelling, and also sexual dysfunction. To simplify the approach to the pelvic floor, it was divided into three compartments: the anterior, the middle, and the posterior. This compartmentalization has led to the patient being referred to a single specialist, such as a urologist, a gynecologist, or a colorectal surgeon. However, multiple compartmental disease is more common than an alteration of a single compartment alone. So why is posterior compartment prolapse relevant in clinical practice? It's really because of its prevalence, especially in women over the age of 80, and also in the elderly population in general. And a survey has been done and found that more than half of the nursing home residents suffer from posterior compartment prolapse. So one of the main symptoms of posterior compartment prolapse is obstructive defecation. This is a very complex syndrome, and the symptomatology is very variable. So the patient describes a difficulty in evacuation or emptying of the rectum, straining and rectal, perineal, and vaginal digitation, fragmented defecation, and rectal pain. And obstructive defecation syndrome, also known as ODS, can be related to pelvic floor incoordination, anismus, and also anatomic abnormalities, on which we shall focus. So the key anatomical defect underlying obstructive defecation syndrome is rectal redundancy. And this happens because of chronic straining, which produces stretching and redundancy of the distal rectum. Patients who present with an internal prolapse this is the result of rectal invagination and intussusception. Transverse distension of the rectum leads to a rectocele, and distal elongation to perineal descent, and then to rectal prolapse. So the initial compensatory mechanisms facilitate opening of the rectal lumen, but then gradual impaired ability to generate intrarectal pressure for evacuation may lead to prolapse of the small bowel, known as enterocele, and the perineum. So rectal prolapse can either be mucosal or full thickness, and this is the result of laxity of the supporting ligaments of the rectum, and the patient is diagnosed on rectal examination and the presence of a mass protruding out of the anus. So this initially is present with straining, but then that the condition may progress to exteriorization with any increase in intra-abdominal pressure. Fecal incontinence is associated with this condition in between 50 to 75% of patients. It's important that a basal assessment is carried out in all patients, thorough medical history, quality of life assessments, and also a general and anorectal examination. We tend to use the Lumini X1, which is a video rigid sigmoidoscope, in the assessment of our patients. Specialized investigations are very important. A colonoscopy is used selectively, especially in patients with reflex symptoms or those with a positive Q-fit test. Colonic transit studies are very important because we need to exclude slow transit constipation. We have a 3D B&K endoanal ultrasound, which gives us a thorough visualization of the anal sphincter morphology. And then we have a variety of anorectal manometry and sensory function tests and neurophysiological tests, which give us a thorough assessment of nerve function, especially pudendal nerve function. A very important investigation is defecating proctogram. So this will give us an evaluation of rectal evacuation. So this could be done either by fluoroscopy or by MRI. The initial treatment is basically conservative. It involves a multidisciplinary approach, usually using stool softeners, prokinetics, pelvic floor physiotherapy, biofeedback in selected patients, and rectal and colonic irrigation. Surgical treatment follows the process of management of these patients. If conservative measures fail, treatment decisions are to be made on the patient's symptoms and on the impact that these symptoms are having on the quality of life. As mentioned before, there are an overwhelming number of surgical procedures described, from the simple to the very complex. But we can classify these procedures into three. We've got transanal procedures, we've got the perineal procedures, and the abdominal ones. So we'll go over these in turn. The choice of the optimum approach is usually dictated by the patient's general condition, which is the age, comorbidities, and bowel function, other pelvic organ prolapse, so you may have cystocele, vaginal vault prolapse, and also the surgeon's experience and preference. So this algorithm we tend to use, and this illustrates the complexity of our decision making in pelvic organ prolapse. So you have the patients with internal rectal prolapse and rectocele, patients with external rectal prolapse, and also patients with middle and anterior compartmental prolapse, such as cystocele, hysterocele, and vaginal vault. And you can see the interaction between these conditions and the complexity of operations to deal with these conditions together. So one of the procedures that is commonly used in patients with rectal intussusception and rectocele is the internal Delorme. So this is a transanal resection of prolapsed rectal mucosa, plication of the rectal wall muscle, and the mucomucosal anastomosis. It is a straightforward operation, but as with each and every other operation, there are complications. And the main complication of this is bleeding. Anastomotic stenosis requiring surgical treatment may occur, as well as anorectal pain and acute urinary retention. However, good results have been described with this procedure. Delorme's operation is also used for external rectal prolapse. So the external Delorme, as we know, is rectal mucosectomy followed by muscular plication. The proximal mucosa is anastomosed to the distal margin of the mucosal resection. And this procedure is preferred for a short segment prolapse. It's very well tolerated by the elderly. However, it has a recurrence rate of up to 20%. The complication rate is low. It's mainly bleeding, and also fecal impaction and mucosal necrosis has been described. Moving on to the STAR procedure. So we've heard about the STAR procedure, which and this operation aims to correct the anatomical defects associated with obstructive defecation. So there are three stapling techniques used. There's the PPH-01 stapler, which was originally used for hemorrhoids. We've got the contour TransStar stapler and the laparoscopic linear cutting stapler, like the EndoGIA. The PPH STAR procedure was originally, it's based on the stapled hemorrhoidopexy, originally described by Longo. The STAR procedure using this stapling gun was originally used without good published evidence for efficacy, efficiency, and safety. This raised concerns among the surgical community, and then in turn, it led to the establishment of intercontinental registries to address these concerns. In fact, the first registry for this procedure was the European STAR registry, which has in its first issue about 3,000 consecutive patients. And the importance of this registry was to determine the surgical techniques used, but also the complication rate. And in fact, the publication using data from this registry showed that postoperative fecal urgency is present in about a fifth of patients. There are the usual bleeding and septic events, staple line complications, and incontinence. However, the registry also picked up very serious complications, rectal necrosis and rectovaginal fistula amongst of them, with patients suffering serious harm. Other studies have shown, quite good outcomes with, favorable data. So from this stapler, we then move on to the contour TransStar, which is really a modification and, in my opinion, improvement over the PPH stapler. So likewise, registries have been set up for this type of stapler. Complication rates have been described, which include bleeding, staple line complications. However, the conclusion is that with this type of stapler, it represents a safe and effective treatment for obstructive defecation in local clinical practice. The major concern with these, two staplers is that is a blind procedure. So the staple guns pose a potential threat to the structures lying anterior to the rectal wall in the pouch of Douglas. As an enterocele is a common finding in these patients with pelvic floor disorders, it is important to establish the presence or absence of an enterocoel with defecography. So a technique that has been described, and something that I use myself, is the use of the linear cutting staplers, also known as the Bressler technique. So rather than using a PPH stapler or a control transfer stapler, we use a laparoscopic linear cutting stapler such as the EndoGIA, which is done under direct vision. The short-term results and the long-term results have been good. The majority of patients having good symptomatic relief and good quality of life. I can share our experience. We reserve the STAR technique using this stapler for grade 2 or grade 3 symptomatic rectocele with no other major pelvic organ prolapse. So this is solely for rectocele. Mean operating time was about 35 minutes. Mean hospital stay was about 2 days. The immediate postoperative complications were persistent rectal bleeding, which required the patient to pay another visit to theater, and acute retention of urine. We also looked at the 5-year results. Certainly, this procedure helped improve obstructive defecation syndrome. The main problem with this procedure in the immediate postoperative period and the early postoperative period is fecal urgency. So we had in the first 3 months, 41% of patients who had fecal urgency, not so much as urge fecal incontinence, but mainly urgency. But this symptom gets better with time. The Altmaier operation is also known as the perineal rectosigmoidectomy. It's an operation that involves dissection into the peritoneal cavity via the prolapse peritoneal lining of the pouch of Douglas, followed by excision of the rectum and sigmoid colon and a coloanal anastomosis. The anastomosis is usually done by hand and occasionally, as we heard in the previous presentation, occasionally described by a stapler. I always combine this, and in fact, the literature has shown that the best results are achieved when combined with a pelvic floor repair, elevatorplasty. And the perineal operation may be carried out in those who are unfit under regional anesthetic. So the results are here tabulated, and this operation has certainly achieved quite a lot of success. And it's not only an operation for the elderly, but applicable to all age groups. Al-Wahid et al. In a study carried out in Dundee and published recently showed that the Altmaier operation is very effective in resolving the rectal mass, in improving a patient's fecal incontinence, and also constipation, obstructive defecation. The morbidity complication rate was about 30%, mainly bleeding and some anastomotic infection, but also recurrence as well. However, there were no deaths within 30 days, and the outcomes were comparable in both the younger age group and also the more elderly patient group. The abdominal approach is another way to deal with patients with posterior compartment prolapse. Abdominal surgery may be performed either open or laparoscopically, and now even robotically. In fact, may I mention that we've got a conference in our college on the 1st of March, and we are going to delve in more detail on the robotic approach to pelvic organ prolapse, especially posterior compartment prolapse. Abdominal rectopexy entails rectal mobilization and fixation to the sacrum with either sutures or mesh. Rectopexy may be performed either posteriorly with an Ivalent sponge, and this is known as the Wells procedure. Fascia lata may be used in the Orlog operation or non-absorbable mesh. Or else The procedure may be performed anteriorly, ventrally, with an anterior mesh sling around the rectum, so between the rectum to the sacrum, and is also known as the Ripstein's procedure, or a ventral mesh rectopexy. Resection during an abdominal rectopexy is also known as the Freichmann-Goldberg procedure and usually involves resection of the sigmoid colon with a hand-sewn or stapled anastomosis at the sacral promontory. So laparoscopic ventral mesh rectopexy has really taken up favor amongst pelvic floor surgeons over the last 5 to 10 years. And the definitive indication for this operation is for patients with external rectal prolapse who are deemed fit for anesthesia. Patients with symptomatic high-grade internal rectal prolapse with failed conservative therapy are also main candidates for this operation, and also patients with a solitary rectal ulcer syndrome. This operation is contraindicated in men because the operation will be very difficult and there are greater potential risks, and also patients with morbid obesity, and also patients with pelvic floor inflammatory conditions such as high-grade endometriosis, diverticulitis, and those who had previous pelvic radiotherapy. It's absolutely contraindicated in pregnancy and also in patients with severe intra-abdominal adhesions from previous surgery. The advantages of this operation is that it is nerve sparing. So you don't have the posterior dissection and the risk of damaging the pelvic nerves, because this avoids rectal mobilization and there is no perisphincteric dissection. And this operation can address multiple problems. It can address the intussusception, rectocele, enterocele, and sigmoidocele, but can also be combined with repair of another pelvic organ. So frequently, it's a combined procedure with the gynecologist who would like to carry out a sacral colpopexy. The controversy is within the use of mesh. Mesh provides stability by mechanical support and encourages scar formation. However, we know that the synthetic mesh has caused problems. In fact, it is banned in Scotland. And this is because of erosion and infection. So there are dilemmas in the abdominal approach. What about the dissection? Would you go posteriorly? If you do a posterior approach, how far posteriorly? What about anteriorly? How far anteriorly does one dissect? Whether one should fix the rectum or not, whether one should use mesh or not, whether one should resect the sigmoid colon or not, and whether to divide the lateral ligaments. So these dilemmas have been addressed or partially addressed in the literature. There is evidence that shows that rectopexy combined with resection caused less constipation. There's no difference in what sort of mesh or fixation method is used. And the recurrence rate in patients whose rectum was fixed is much lower after 5 years in those who did not have any fixation. So the results of ventral mesh rectopexy are very good, especially with the laparoscopic approach. In fact, conclusion of one paper is that LAP VMR is safe and effective for the treatment of different rectal prolapse syndromes. The long-term recurrence rates are in line with the classic types of mesh rectopexy, and occurrence of mesh-related complications is rare. In fact, the complications with synthetic mesh is to the order of 2.4%. However, despite that, synthetic mesh is banned. And we tend to use biologic mesh because it's safer and the risk of complications is very low. So further studies have compared synthetic versus biologic mesh. The only problem with biologic mesh is that it is more expensive and can significantly increase the cost of the operation. And also technically, it is more difficult to suture a biologic mesh to the sacral promontory. But the use of biologic mesh can be used in patients who have Crohn's disease and diverticular disease as well. We mentioned before the PROSPER trial, and this is a randomized comparison of surgical treatments for rectal prolapse in order to address the dilemma. What should be used? Is the best approach the abdominal approach, which has taken ground, or is it the perineal approach? So the PROSPER study has been designed to try to address this problem. However, the results of this trial did not show any difference between either approach. The recurrence rates between the abdominal and the perineal operations are nearly identical. And also there is not much difference in terms of complication rates and recurrence between the Delorme's and the Altmaier procedure. We do have further evidence. So the Cochrane review in 2015 assessed the effects of different surgical repairs for complete rectal prolapse. And the conclusion is that, first of all, the studies are too small to draw any meaningful conclusions, and there have been some methodological weaknesses. But there is no obvious difference in recurrence between the abdominal and the perineal approach. The laparoscopic procedure is preferred because of the less morbidity and more rapid discharge home compared to the open procedure. Recently, a study has been published from Italy by Pellino. So this is a meta-analysis and review of both randomized controlled trials and non-randomized trials when comparing the abdominal approach versus the perineal approach to rectal prolapse. And when the randomized trials were analyzed, there is no difference. However, in the non-randomized trials were analyzed, these showed that there is a difference in that the abdominal approach is more superior. That is, there is less recurrence compared to the perineal approach. However, the criticism of this study is that it included studies with very small numbers, so one cannot make any meaningful conclusions. I want to touch upon the different approaches that we have for rectal prolapse. So there has been a study recently looking at the international variability of surgery for rectal prolapse. And there has been a difference between surgeons from Australia, Europe, and the Americas. First of all, in terms of preoperative evaluation, only 19% would perform anorectal physiology testing, and 70% would evaluate for concomitant pelvic organ prolapse. The surgical approaches are different. For example, in terms of ventrirectopexy, in the Americas, a synthetic mesh approach is preferred, whereas surgeons from Australia prefer biologic grafts. And surgeons in patients with comorbidities prefer a perineal approach. However, this differs from country to country as to whether to carry out the Delorme approach or the Altmaier operation. And this gets us back to the algorithm that we had mentioned before. Certainly, transanal and transabdominal approaches have been described. The first line of treatment for obstructive defecation due to internal rectal prolapse and supraperineal row rectocele is the STAR procedure. So if it is a simple rectocele or a simple prolapse, the STAR procedure is the preferred one. Now, which stapling gun to use, that is subject to debate. I would personally prefer the linear stapler because it involves a direct visualization of the tissues rather than a blind procedure. Then there is the surgery for external rectal prolapse. In high-risk patients with a small prolapse, probably the external Delorme is preferred. Those patients with a longer rectal prolapse can either have an Altmaier procedure, which is quite successful, but can also have a ventral mesh rectopexy. So that depends then on the experience of the surgeon. Patients, however, who have either middle or anterior compartment prolapse probably would best benefit from a ventral mesh rectopexy if a gynecological or a urological operation is going to take place. So one word about recurrent prolapse. So recurrent prolapse is a problem with, whichever, as we have seen, with whichever technique is used. So what gives rise to recurrent prolapse? So we have patient-related factors such as gender, body mass index, and a prior history of prolapse repair. We have technical factors such as inadequate anterior rectal dissection, inadequate fixation of the mesh to the anterior rectal wall or the sacral promontory. And we have also patients who have various issues with their pelvic floor itself. In perineal approaches, a stapled anastomosis, shorter specimen length, and severe pre-existing constipation are associated with an increased risk of recurrence. And also a prolonged pudendal nerve terminal motor latency, which indicates denervation of the external anal sphincter, is predictive of recurrence. So it's very important, especially in patients who have fecal incontinence as well as erectile prolapse, that a full anorectal manometry and neurophysiology studies are carried out, in particular to detect any pudendal nerve damage, especially after childbirth. Because if there is a pudendal nerve damage, if there is neurological damage, then the operation for prolapse, irrespective of what type of operation is carried out, that operation will fail and will recur. So how does one manage a recurrent rectal prolapse? Basically, there is no appropriate surgical guideline. It all depends on the expertise of the center, on the expertise of the surgeon. Certainly, it's important to investigate this thoroughly. And the type of surgery should be chosen according to the previous surgery for prolapse and the clinical condition of the patient. So usually, I mean, there's a group who advocate that if a perineal approach has been carried out, then one should have an abdominal approach and vice versa. If a resection was carried out, it is important to resect the prior anastomosis to avoid leaving an ischemic segment of sigmoid colon. Therefore, in conclusion, we know that posterior compartment prolapse is a common problem, and it's also multifactorial. Conservative approach is key, and if there's failure of conservative management, then operative surgery should be considered. Patients should be fully investigated prior to surgery. There should be no shortcuts, so patients should have, in order to tailor the type of the appropriate operation to the patient needs to be investigated. And it's very important that any decisions are taken in a multidisciplinary team approach. And the surgeon, especially the surgical team, should be technically competent in all major perineal and abdominal approaches. And the operations should be tailored as opposed to a blanket approach for all organ prolapse. These procedures, because there's no consensus, no agreement, so there are implications for research. And there is a need for trials with adequate power and long-term follow-up to evaluate the reliability of each existing prolapse repair technique. Thank you very much. That concludes my talk. Thank you for the opportunity. May I finish off by mentioning the MRCS Part B exam that we're very privileged to be conducting in Delhi from the 1st to the 3rd of May. And so far, I've been told we already have about 50 applicants for this exam. So that's great. Thank you very much.
Thank you, John. That was a real wonderful exposition of the topic. You have covered it extensively. And if you believe it, there are few questions people have posted on the YouTube, which I have copied and I will be conveying to you. So you can. The first question what I have got on the net is, what is the association between rapid weight loss due to bariatric surgery and pelvic organ prolapse? Roy, would you like to take this?
Yeah, I'm not aware of any published data that links rapid weight loss to rectal prolapse. And I fail to see the logic why weight loss would cause a prolapse, because I don't see how the pelvic floor function would deteriorate because of weight loss.
John, would you like to add?
Yes, I agree completely. In fact, obesity, morbid obesity is one of the risk factors for pelvic organ prolapse. So actually losing weight should actually help. However, if you have extreme weight loss, as in cachexia, then you're going to have loss of muscle function, and that could also compromise the function of the pelvic floor. But certainly, if one is going to lose weight as a result of a bariatric procedure, as long as the muscle mass remains adequate, remains within normal limits, then pelvic organ prolapse should not take place.
Yeah, I have another question. Is there any emerging or experimental treatments for pelvic organ prolapse that show promise in improving outcomes or reducing the need for surgery? Are there any experimental studies or procedures? I don't know what actually means.
No, I mean, so the I think if I were to choose one single investigation, would be apart from a proctoscopy, would be a defecating proctogram. I think both agree that a proctogram gives an excellent visualization of the extent of the prolapse, and also looks at the pelvic floor as well, especially MRI defecating proctogram. Yes, there could be some false positives, but I feel that that is a very important investigation to carry out. However, then this would be in combination with anorectal physiology and manometry.
Completely agree, John. I think these are, may I?
Go ahead, Roy.
So these are two separate groups. One is full thickness rectal prolapse and other is obstructive defecation. So obstructive defecation can happen with or without prolapse and is actually a very complex and multifactorial problem which needs a very thorough evaluation. About 5 to 7% of patients have a history of sexual or physical abuse, and it can be to some extent a supratentorial event as well. So you need to be very careful advising surgery to anybody with a obstructive defecation syndrome. But as John said, I think I go against what the AGA says. We always do imaging with MR diffeography, which visualizes all three compartments. If there is no structural abnormality, then we offer them on manometry. That is our take as well. I agree with John.
John, I saw in your presentation, you said trial of conservative treatment. What actually you would advise these patients, set of patients, probably in early stage or whatever, what measures would you advise?
So the conservative measures would be, first of all, we need to make sure that they have a good technique in opening their bowels. You see, and so if they are straining too much, then they may need the use of enemas and sometimes rectal irrigation. However, obstructive defecation can also be combined with slow transit constipation. They are two separate entities, but they occur together. So it's very important to rule out slow transit constipation first. So if the patient does have this condition, then they may need the use of laxatives. And also we have prokinetic agents such as linaclotide and procalopride. And these medications have revolutionized the management of slow transit. You see, so it's mainly the important thing is to eliminate slow transit constipation and make sure that the rectum itself is well irrigated, and in order to help defecation.
Okay.
I agree, Siddesh. May I?
Yeah.
So I think ODS it's I don't think it's one solution for all. It's horses for courses. I think as time progresses with gray hair, I'm realizing that you need to be as conservative as possible in offering surgery to a patient with ODS. Let the patient earn the operation. Adequate conservative treatment. In my practice, prucalopride has had very limited value. I still would go with bulking and stimulant laxatives. I really lay a lot of stress to psychological evaluation of these people, a good 3 or 4 sessions of biofeedback and pelvic floor training, despite having anatomical abnormality. And we separate the wheat from the chaff. If we feel that the patient has psychosomatic overlay, we make sure we don't offer surgery, because these are patients who will bug you. So be very, very careful offering surgery for ODS. On the other hand, a full thickness rectal prolapse almost invariably does well with surgery. So these are 2 different groups of patients we need to address differently.
Can I ask a question to Roy?
Yeah.
Roy, you have done a lot of work on biofeedback, and it's published in the literature as well. For the audience's sake, could you tell us exactly what do you mean by biofeedback, apart from Kegel's exercises, as you said? Anything?
So
what exactly do you do in biofeedback?
So biofeedback basically is pelvic floor retraining. One part of that is muscle strengthening, like the Kegels, and Kegels is one small part of that. There are some patients who come to see the ODS is like a very vast spectrum of disease. You have patients with SRUS, you have patients with anismus, you have patients who have trigger point pain, who have dyspareunia, and a lot of these patients need relaxation exercise. So what we do in our clinic is we have a special manometry system where we put transvaginal electrodes and electrodes on the thigh, and we actually teach the patient how to relax the sphincter and how to contract the sphincter. We can actually produce graphs of performance based on that. We are also big into using yogic exercises. I think many things like Ashwini Mudra, Mool Bandhasan, which are available on YouTube, and I give a printout with some YouTube links to my patients, where our physiotherapist guides them in various yogic exercises. So it's just not contraction and pelvic floor training, it's teaching the patient how to defecate. And I think I would never advise surgery for ODS unless he or she finishes at least 3 sessions of biofeedback. And believe me, about 40% of patients with proven structural abnormalities do well with lifestyle change, laxatives, and biofeedback. They don't come to surgery. I'm very happy with that.
Thank you.
Roy, what is your decision on children having prolapse? How do you approach them?
So, Siddesh, I don't treat children below 12, but the general understanding is many times this is because of diarrhea and is generally treated conservatively. In our country, malnutrition and diarrhea is an important part. So treat the diarrhea, treat the malnutrition. A small percentage of patients may require a sclerotherapy, which causes submucous fibrosis and prevents prolapse. But most times, the children will outgrow the prolapse by the time they're 14.
I agree with you. Yeah. Over a course of years, have you shifted from posterior? You started with posterior, now you have become exclusively anterior rectopexy surgeon. I mean, laparoscopic anterior rectopexy is your procedure of choice in those selected patients. You never do posterior rectopexy at all.
So in the last 10 years, I haven't done a posterior rectopexy. I really don't find any reason to denervate the rectal ampulla or divide the lateral ligaments. I think as much as the structural prevention of prolapse, it is looking at the functional quality of life and evacuation that the patient has after rectopexy. I don't think we lay equal importance to quality of life and evacuation. It's not incontinence and structural thing. That happens in every patient. It is good evacuation, prevention of de novo constipation, and pelvic floor retraining. And for that, ventral rectopexy is any day better. In patients with slow transit constipation, I still do the Friedman Goldberg's resection rectopexy. But in everyone else, I'm a VMR fan.
Okay. John, I would ask the last question from my side. what any particular measures would you like to take in preparing the patients when they are definite indication for surgery to prevent the complications?
Yeah, so make sure that they are fit for surgery, for general anesthetic first of all. But we do have, yes, I mean, a significant proportion of patients who are not fit for a general anesthetic, but would be need to be considered for a regional anesthetic. So if they are not fit for a general anesthetic, then we are then constrained to do a perineal approach. The main thing is the BMI of the patient. So patients with a high BMI are more prone to developing complications. So as part of the conservative measures, we also employ targeted weight loss because we know that the outcome in patients who have a normal BMI is much better than the morbidly obese. So that is part of the workup, and also by assessing the patient's pelvic floor in terms of neurophysiology in selected patients, especially those who had a perineal injury or suspected pudendal nerve injury, then it's very important to assess this and rule this condition out completely. Because otherwise, if one carries out a prolapse procedure, whether abdominal or perineal, and if the patient has a weak pelvic floor as a result of a pelvic and pudendal nerve injury, then the outcome, the risk of recurrence is going to be higher. So patients will need a more extensive period of physiotherapy, biofeedback to help.
Thank you. Is there any other question from the people who are available on the platform here on Zoom? Otherwise, we'll say thank you very much for both the speakers for having done a wonderful job and having spared time to share your views in answering those few questions. So I would request now to go requesting Professor Abhay Rane, Registrar of Royal College of Physicians and Surgeons of Glasgow, to make his concluding remarks. Abhay?
Thank you. Yes, well, it was an absolute tour de force, I think. The two speakers really gave us food for thought, I hope. And I trust that our trainees and the junior surgeons on the call got what they wanted from the excellent webinar. I certainly learned a lot, and I'm a urologist, so I learned a lot about pelvic floor, and and a lot of it was very relevant. And so I thank both the speakers for all the effort and the time they've taken to put together these really good presentations. I think I'd also like to take this opportunity to thank the Association of Surgeons of India for entering this collaborative venture with the college, and we look forward to working with you in the years to come on further such webinars and anything else that can move our two organizations closer together. So yes, thank you again for everything, and thank you to all the attendees for participating and making it such an interactive program. Thank you.
Thank you. Before we go for the formal vote of thanks, I would request the person who has been working hard to make this exchange program successful, that is none other than Dr. P. Raghuram, the convener of External Affairs of the Association Surgeons of India, has been the past president as well. So I request Raghu, please come in.
Thank you, Siddesh. Good afternoon and good evening to everyone. Sharp, succinct and informative presentations from both Roy and John. Many thanks to both of them. As convener for international affairs for ASI, certainly the last couple of years, we have witnessed that the overseas academic activities have been on a roll. And as someone involved with the international activities of ASI for a number of years, I can say this for a fact, that our friendship, translating to meaningful academic initiatives between ASI and the Royal College of Physicians and Surgeons of Glasgow has been the quickest thus far. And I must give credit for this quick transformation to the presidents of both the organizations, whose personal friendship has resulted in this. And of course, Abhay, dear friend, Abhay has been a catalyst. He was the vice president of the college when all of this started in December 2022. And now as the registrar, he's really been instrumental in bridging the links between our associations, which I'm sure will benefit the membership at large. And I very much look forward to the next couple of webinars, something which is very close to my heart, on ABCs of benign breast disease, which would be held online on the 19th of April and 5th of July. Thank you very much.
Thank you, Raghu. It was wonderful. Thank you for your continued efforts. And I would request the Honorary Secretary of the Association Surgeons of India, Dr. Pratap Uruche, please come in for the formal vote of thanks.
Thank you very much, dear Siddesh sir. It's indeed my proud privilege and honor to propose vote of thanks to all the dignitaries present here today, as well as to all the viewers on the ASI YouTube channel from entire nation and abroad. The Association of Surgeons of India and the Royal College of Physicians and Surgeons of Glasgow are at the forefronts of educational activities, and that is been entirely reflected through today's webinar. On behalf of ASI headquarters and the entire executive committee of ASI, I must thank the heads of both the associations, Honorable President ASI, Dr. Prabol Neogi, and Honorable President, Royal College of Physicians and Surgeons of Glasgow, Dr. Mike McCurdy, for their presence, active participation, and steadfast support extended towards this webinar series. On 6th of October, we initiated this webinar series. The topic was perianal sepsis, and today we have successfully conducted our second webinar on pelvic floor prolapse. I also thank the principal office bearers of ASI, Vice President Dr. Praveen Suryavanshi, and Treasurer Dr. Bhavarlal Yadav for their active involvement. I thank Director Academic Council, ASI, past President Dr. G. Siddesh, immediate past President Dr. Sanjay Kumar Jain, Convener International Affairs ASI, Dr. P. Raghuram, OBE, Dr. John Robertson from Royal College of Physicians and Surgeons of Glasgow, and our own dear friend, Professor Dr. Abhay Rane, OBE, College Registrar and Associate Director, the Royal College of Physicians and Surgeons of Glasgow, for their consistent efforts to build a strong alliance between these two world-renowned organizations. A big thank you to our today's esteemed speakers, Dr. Roy Sunil Patankar, a senior executive committee member of ASI, a renowned GI surgeon from Mumbai, India, and John Camilleri Brennan, a renowned colorectal surgeon from RCPSG, for enlightening us with their vast experience on this very important topic, that is pelvic organ prolapse. This topic is very crucial in every surgeon's professional life, but it is often neglected. We all are deeply indebted to both of you for sharing your experiences, knowledge, and ways to manage this condition. I also appreciate the technical help provided by Mr. Avneet for the flawless transmission for the entire webinar. Lastly, most grateful to the entire membership, consultants, postgraduate students from entire globe for joining in for today's webinar. We will be back soon with our third episode of this webinar series with yet another interesting topic. Long live the Association of Surgeons of India. Long live the Royal College of Physicians of Surgeons of Glasgow. Jai Hind. Thank you very much.
Thank you. Thank you.
Thank you very much.
That was wonderful way of concluding. Thank you all for joining. Hope
Thank you.
we will solve all the glitches and we may meet next. Thank you. We will stop the recording now.